General, thank you. A lot of food for thought on this panel, a lot of questions, a lot of insights, and my one vaccine trivia of the day. Tomorrow, May 14th in 1796 was when Edward Jenner first used the smallpox vaccine on an 8-year-old boy. So maybe useless, but interesting, and I hope they're using modern technology to deal with that. Before I open it up to the audience, I want to identify 3 of our primary faculty who've been wonderful at GW to see if they want to provide some questions, some insights, or if they have remarks. Rebecca Katz at the School of Public Health, she was the principal author of a report we recently did jointly. We have Amir Afkhami, who wrote an award-winning dissertation on the 1918 flu, who's over at the Department of Psychiatry, and then we also have Dr. Lisa May at the GW Department of Medicine, and where the rubber really does hit the road to some extent is in the ER, and how do we engage in some of these issues. So I'd like these 3 to have an opportunity to share some thoughts. If the panelists have any questions among themselves, that would be great, and then we want to turn it over to the audience. So, Rebecca?
I just want a question for the panelists, and maybe you could comment on the role of the World Health Organization over the last couple of weeks. And do you believe they've been effective? The travel and trade recommendations were followed by many nations, but not all. Do you think this is indicative of the level of their authority in a response? And also following from that, have you seen a domestic commitment to follow the international health regulations?
Oh, it's me. Okay. I guess I drew the short straw.
You got 2 mics near you, Bob.
Yeah, really. Well, first of all, on the performance of the WHO organization, first of all, we are blessed by the fact that we have someone as experienced as Margaret Chan in that position. Someone who has, dealt with, potential pandemics, both SARS and the first outbreak of the bird flu. So she is what I would say a seasoned veteran. And with that, I think that from the standpoint of what WHO role is in this situation is to advise states parties and states members to their responsibilities and provide guidance, particularly overarching guidance, it has been good. However, as been pointed out by Jeff earlier, the mechanisms, the stages that were created for pandemic flu were really done on the assumption, correct or incorrect, on a highly lethal virulent strain like H5N1. So in some ways, the tools they're using are suffering from the same limitations that we are. Subject to the international health recommendations around travel restrictions and the like, I think that's one where I think you have to tread lightly. And again, realizing that in some ways those things are reasonable in light of what was emerging information, incomplete information. So in some ways, you may have some reconsideration of some of those recommendations in light of what we are learning about the strain as it exists today. But overall, if I had to give them a mark, I'd give them a kind of a B+. Again, they don't have extensive authorities. Again, they have the bully pulpit, and I think in some ways to confer the tone as Margaret Chan has, which is serious concern. And again, a point made earlier is that the Western world the developed world is can be a little, I won't say less concerned, but for the developing world, clearly that there are issues there when you don't have vaccine manufacturing, when you don't have stockpiles of antivirals. What do you have left? And he gets into a sort of common sense set of principles that have been obviously used here about washing hands and whatever, personal hygiene, but also about social mitigation techniques, which, as Dr. Russell says, doesn't necessarily change the area under the curve, but certainly lowers the peak of that curve over time and buys time for the use of other mechanisms that may be available. Buy times potentially where new and developing vaccine technologies could be used. One thing to highlight what Dr. Russell mentioned is that of all places, DARPA, the people that brought you the Saturn V missile and a variety of other innovations, including the internet, I've been working on at the behest of the White House, looking at alternative and advanced technologies for vaccine manufacturing that would significantly expedite the time and significantly decrease the cost of vaccines. So in some ways, getting back to the original question of WHO, I think what they've done so far has been appropriate. They don't have many tools, but I think the tools they've used so far, they've used judiciously, and like everyone else, they're learning as they go along with this virus, and I think they have effective leadership to basically do the right kinds of things as we go forward.
Jeff, you were the one who raised the lash-up between, say, the intelligence community, and it's been a challenge to get traditional collectors to have an appreciation for science and technology and very unique targets and have an appreciation for that. And the flip side, to get the science and technology community to get a better appreciation for what our overall communities. Do you want to footnote any of that? Because
no, I don't know. The footnote would be that obviously different. There's both within our own country the intelligence resources and the surveillance capacity, and then the capacity through the WHO and other mechanisms to create greater surveillance capacity around the world, and the underfunding of the CDC's Global Disease Detection Program. There are many different ways that we can build this up. We can learn some lessons from what happened in the Mexico incident, but Mexico has a relatively developed public health system. If this happened elsewhere, we could have difficulties. And we saw, and I think this comes back to the equity issue, there are some, put aside just the social injustice of having these kinds of differential access. If, as we saw with getting access to the H5N1 virus and Indonesia holding up access to that because of concern about access to vaccine, and that they were really just going to be providing a virus to be cultured to be used in the developed world. I mean, I think those are very real potential obstacles in the context of a pandemic where we are going to need to move very quickly, and if we don't start addressing those with really clear policies and improved technologies that make those policies possible and real, we could face some real challenges domestically because of that.
If I could comment, one of the things we still have to deal with is how do these two sets of information come together? And there were points at which the Homeland Security representatives in the states were getting information hours before the public health officials were. And at a point when the CDC was reporting only confirms, Homeland Security was reporting probables. And so it was by information being handed over from the Homeland Security representatives to the public health officials that they were learning much of what was going on in the country. Now, I think the CDC caught up, but I'm not sure that it's appropriate that that's happening, because the people actually that were required to take the action were the public health officials, and they weren't being provided the information. So somehow in this country, we got to figure out how the people with the stethoscopes and the guys with the guns and hoses can talk to each other in a way that's meaningful and they trust each other with it.
Well, I think that's a very valid set of issues, and it goes beyond just H1N1 into a whole host of various areas, and one that I think the community is still nascent in terms of how it, not only the push down, but the pull up, and from what sources and how that's integrated. And I think those are really key sets of issues, and we're looking at through other contexts, vis-a-vis violent extremism and radicalization and the like. Amir, anything 1918 reminiscent? I might note that the phases initially concerned me because I felt like deja vu a little bit with the Homeland Security Advisory System and the color-coded project, so I'd be curious what your thoughts are on that afterwards. But Amir, why don't you?
As the psychiatrist in the group, have to say that human behavior is the wild card in this setting. During the 1918 flu pandemic, while some period-appropriate attempts were made by the Public Health Service to have social isolation. People in the United States were still attending church services, going to World War I bond rallies. Thereby, some of this was defeated. What is our understanding today from not a theoretical perspective, but from an empirical perspective, based on, for example, the Australian experience with the equine outbreak and other recent outbreaks in the past, as to how Americans will react to restrictive measures, to other mandates coming down from local and federal health authorities? And how will this affect the progress of a potential cataclysmic outbreak?
As far as I'm aware, Bob Blendon's probably done the best surveying out of Harvard of the public and who they trust as a credible spokesperson and to what extent they will follow that advice. And he did, I think, a survey of 2 weeks ago did update that. And I can't give you the results other than to say it was pretty good, not great. What I find more concerning, though, in a lot of the conversations that we have, is the response to the outbreaks are typically driven by scientists with a belief that science will determine what happens, and without the appreciation that, in fact, public health and clinical and other scientists can only basically put out guidance, but the politicians and the public actually decide what's going to happen. It's the parents who decide whether they're going to send their kid to school or not. It's the principal who decides whether to cancel it. It isn't the scientists. And so one of my broken record on all those calls is, wait a minute, this is a dance we're doing here, and we've got to understand the mindset of the people when you make a recommendation, and not stay out of touch or you lose credibility. So again, that is my one concern, is science doesn't determine what happens, it's people. And so we need to learn a lot more about that.
And especially as it pertains to new technologies and social networking, which is a great opportunity, but it also provides some challenges.
Sure, Frank, if I could just add one quick thing, is that there's another wild card that I don't think that existed in 1918 is the media that we have today. And I think a lot of people's behavior will be determined on the view or the perception of how they view the threat, or if there is a threat, if it's a credible threat. If they perceive now that it's a hype threat, what will happen if it reemerges later on and it comes back? Will they be desensitized? Will they be? And I think part of the quote-unquote panic that we experienced, with this most recent set of events was really the sensitization of people to the H5N1 threat. They couldn't tell the difference between H1N1 or H5N1, but they knew it was a pandemic threat. It looked bad. Credible people were talking about concern, and I think that, that was a base from which people responded. So I think part of it is now in this interregnum, it would seem like it would be important, if I were still in government, to talk to the media and make sure they got the facts right, and that they were operating from, if you will, the same set of facts that everybody else was.
But just to underscore one point, you're not, I mean, as the saying goes, you've seen one strain of flu virus, you've seen one strain of flu virus. Ultimately, what we're talking about is inducing changes in behavior. And are you suggesting that the general public needs to be armed with the same sorts of knowledge as a scientist? No, you're ultimately talking about what behavioral indicators and changes that would induce, yes?
Right.
Okay, because I think that is a key point. And when with West Nile, there have been some surveys done where you really got to get down to the local communicator, where it's not even a scientist necessarily, but places of faith or whoever people trust for that information. Because you're right, Paul, I think it's the mothers. In my household, I know who's boss.
I think the other thing that's not tested, certainly in this experience, is in a true pandemic, we'd need sustained changes in behavior and lives. And, if what happened with school closures after a day or two, parents became impatient, if that were the appropriate response, how will people respond when we're talking for weeks at a time? And I think we don't know the answer to those questions.
Yeah, I think you do.
Yeah.
You already know the answers.
That may well be.
School closures aren't going to work very well.
Well, besides not just in containing the virus, but I'm talking about just, I mean, that as a surrogate for asking people to make major changes in their lives.
We need all of the different social service agencies and everyone involved in this, and that planning has just not gone out far enough.
Larissa?
Yes, I want to thank the panelists for bringing up some very good points. As an emergency physician and public health professional, I felt that actually this was a great drill. It was nowhere near what one might expect in a pandemic, but it was a wonderful drill, and I was very impressed by the communication between the local health authorities and the clinicians, which I think was a great opportunity for the first time in many times perhaps to really have some interaction between those two groups of people. My concern for the summer, for the fall, is being on the ground, we don't have the resources to even do the case finding that the health authorities are recommending. We don't have the resources to swab everyone who comes in with flu. Should we be swabbing all the worried well who don't actually have symptoms of influenza but are concerned for epidemiologic reasons? And how are we actually going to implement the infection control that's recommended? And what are we going to do with all these people? We don't have the logistics to isolate everyone in the emergency department, and we don't even have the nursing staff to provide the care. So what do you think from your perspective would be the necessary policy changes and resources that could come down and trickle down to the people on the ground?
I think this is a great example of efficacy versus effectiveness. I mean, yes, you're going to say everyone should put on an N95 mask, but how practical is that you're going to walk around on your 8-hour shift with an N95 mask? And how many millions of masks do we need? And how are you guys going to take a history and physical from 6 feet across the room? I haven't figured that one out yet. So, so we really have to look at what works on the ground in real life with real people. Not just does an N95 mask work in the laboratory, because if people aren't going to wear them, then maybe a mask is better than nothing. So that's one thing, that practical thing we haven't figured out. I think we also, I sense we confound certain things. For example, the requirements around testing. At a certain point, you're trying to do initial detection, and then you're trying to do case investigation. But once you have it widespread, what are you doing with that test? I mean, how much does that add to your clinical decision making? And we confound epidemiology and clinical treatment. And I don't think we're quite crisp enough in our thinking about when we move from one to the other. As we evolved, at this point, the recommendations are only to test hospitalized patients or severely ill people. And yet, there's still many tests coming in from clinical providers, or from probably because they're demanded by the public. I want to be tested. So we haven't really thought through well enough, when do you make those flips in an outbreak from epidemiological investigation to clinical useful testing?
It's a great point. Does anyone want to build on that? Because it does get back to the larger preparedness, all hazard sets of issues. I mean, what we're talking about is ultimately ramping up from the ordinary to the extraordinary, and how do you build in that capacity for what we do every day, but for a really bad day? And I'd be curious, Larissa, with that, were the physicians and nurses asking specific questions? Because that's been another behavioral set of issues that I'm not sure were accurately identified by others in the past. Will people show up? But I think the real takeaway, not to one-up everyone on the military quotes, but then General Eisenhower said, in preparation for battle, I've often found plans to be useless, but planning to be indispensable. Are we capturing all of these lessons and kicking the tires and doing it and doing it and doing it?
And I also think that we need to distinguish between the level of communication that was occurring with hospitals and with individual practitioners in the field. I have a non-representative sample, but one that suggests to me that people in private practice probably were not responding as one would like them to, or often did not have the knowledge that or the information that they would have liked to have. And I think when we are truly in a pandemic situation, every part of the system is going to have to be able to respond. And it's everything from private practices and how they're going to do triage and talk to folks and make sure that their practices are not breeding grounds for further spread of disease, to health centers, to emergency departments. And I'm not sure, at least in a systematic way, we've worked all that out yet.
Part of it gets back to the problem about how serious are we in terms of our planning. So, for example, when I was in practice, I would frequently call the health department with a question. But we have not supported robustly enough the development of call lines for the public and the providers where you can flip the switch and have it available. Now, many states or most states did stand them up, and about half the calls come from providers. And yet what we're doing is we're taking a whole bunch of telephones and putting them in a conference room and training some people at the last minute to do it. As a nation, we don't have that set up, and we haven't invested in it. And there's lots of, one state, Rhode Island, for example, thousands of calls were coming in, half from the physicians, but it was all stood up on their own, and we can't handle that. So if we're serious, we need to build those communication tools ahead of time.
Well, and I think one of the other takeaways, and I want to open it up to the audience here as well, is, the first responder is often going to be a primary care physician or a family practice or maybe a veterinarian or maybe an agricultural services inspector. It's not what you normally think of necessarily as the traditional first responder or preventer of
astute clinician, we call them,
or a paramedic. These are the sorts of constituencies and communities we want to see raised. I want to quickly open it up to the audience. We've got a great group here. We've got multiple federal agencies represented, whether it's DHHS or DHS or ODNI or USDA or others. We've got some great state and local representation from the first responder community, fire chiefs in the area, as well as other universities and hospitals. So I want to make sure, and of course some of our own faculty, I want to make sure there's an opportunity for everyone to at least bring up some of their questions. We're going to start with the alligators closest to the boat, those closest to me, because they can get us soonest. And then I want to make sure that we have an opportunity to get to those questions. I might note, if you could please identify yourself and your affiliation. Since we don't have roving mics, I'm going to repeat it. It's not that I like to hear myself, but I want to make sure that our viewers have a chance to see that as well. So I see a bunch of hands. We'll start there.
Yeah, Ronald Marks, Senior Fellow at Washington University. I think the question, gentlemen, is one that we've danced around with here for the last 5 years in terms of Homeland security. So I want to go to the point. There's a lot of risk assessment involved in Homeland security. And again, I think all of you have lived that out fairly carefully. There are hundreds and hundreds of aspects of each one of these chess moves that need to be thought about. However, paying for them or having the time resources or the individual resources to devote to them is something else altogether. So I guess what I would ask for a moment is for you all to put yourself in the business of being a risk manager for a second. The difference, as we know, between risk assessment and risk management is something altogether. Risk managers look at their resources, what's available, and how they can best ameliorate the problem. The question I'd like to ask you at this point, if you had to pick a top group, 4, 5, 6, whatever you determine, of issues or of problems or of solutions that you want to address right off the bat that would best ameliorate round 2 of whatever this is going to be, what would you pick?
For the benefit of our viewers, Ron Marks, Senior Fellow at HSPI, former CIA officer, asking the delineation between managing risk and risk assessments and basically prioritization of making the hard choices when there are no easy choices. Anyone?
I'll think of it practically, and I was actually perfectly willing to answer to him. You told me he was a CIA official. I'm scared.
Former.
But without a workforce, we can't do any of it. We've shed 11,000 jobs in last year. We're going to shed another 11,000 jobs. We're projecting the next year. We just can't do it at the state and local level. We need people. And it's not like you can go out and hire people. A lot of these professionals, and I think, as we all know, in preparedness, so much of the human resources is relationships and experience and drilling and training. So when you're cashing these people in and out because you're on one-year cycle grants, you don't ever build a capacity need. So I think workforce is critical. The surveillance is going to be critical. The ability to actually do detection early on, and then feed that up to a point nationally where we have the volume to do some real analysis. The capacity to do real investigation once your surveillance triggers something, to go in there and investigate it. And I think probably in the intelligence world you probably have the logic for analysis of mass volumes of data far beyond what we needed to for health.
I'll let that stand.
Okay, thank you. You cut me a break. And clearly we need the countermeasures. We need to understand, we need the volume to figure this out about what kind of personal protective gear do we really need and how are we going to get out there. We need to figure out the prophylaxis as well as treatment, and what do we need to do that. It's not reasonable to be putting people in harm's way without protection. I think we learned in Katrina that if you don't take care of policemen, they take care of themselves, which means they're not on the job. The same thing's going to happen, I'm sure, to other first responders as well as the public health first responders and the clinical first responders. And then, the legal aspects. There are so many legal issues we've not thought through that are going to trip us up, such as, who can you dispense those countermeasures to? I mean, who can actually, there's transporting, but who can dispense? And does that require one physician, one patient? Or can we have blanket dispensing of medications? Under what conditions? So I would say workforce surveillance and figuring out countermeasures as well as prophylaxis and treatment, and then the legal aspects are my top four. And ask me in 10 minutes, I'll have another 4.
This is clearly an issue vis-a-vis vaccine.
I would add communication capability to that. I think communication capability, both to answer the question of getting information down to the healthcare providers in an organized and effective manner, and to communicate to the public. And I think those are two aspects of it, and I think we've got enough horsepower in it. In answer to your question, I saw an excellent article in, I think, a Journal of Infectious Diseases on the criteria for testing for influenza, clinical criteria, a great guide. But I'm sure that hadn't been read by 85% of the physicians that are actually facing the issue. So translating that information into something that something that's very usable for the doctor facing a room full of patients is a challenge.
Bob, Jeff, anything when you look at the national security issues, we've got unlimited vulnerability, limited resources, an unpredictable Mother Nature, and a thinking adversary. So it really does come down to tough decisions.
Yeah, but I think the game changer in this scenario is vaccine, vaccine, and vaccine. The thing that is going to have the most impact in the evolution of this event, if it were to become more virulent, is going to be vaccine, both domestically and internationally.
Who did we have next? Greg.
Yes, Greg Zadoff, University of Virginia, also senior fellow for HSPI. I think we all agree that communication is essential, but Washington Post recently wrote an article about the contrast between Maryland and Virginia and how they handled this. Maryland being much more transparent and granular, whereas in Virginia, the decision was made to be less transparent, giving the public only a certain amount of information, but not nearly as much as Maryland. In the event of a second wave that is much more virulent, like the 1918 pandemic, which approach would be best? More transparent, granular Maryland approach, or the more opaque Virginia approach?
When answering the question, do you want to repeat the question as well?
Yeah, it was an excellent question about the difference response between different jurisdictions, and some being much more transparent than others, and which is a better approach. I think there's, again, some interesting lessons from 1918 there about, during the face of a world war, many nations did not report on the 1918 outbreak for fear that it would harm the war effort. And I think one of the reasons it's hypothesized called the Spanish flu is because Spain actually did report it in the press, and no one else did, so they called it the Spanish flu, even though they were roadkill in that. I don't know, but the fact of the matter is that in that case, the disconnect between what the government was reporting and what people saw on the ground caused people to lose absolute confidence in authority and the government. And I think if we read The Great Pandemic, it'll talk about how society almost broke down as a result. It became everyone for themselves. So honestly, in the day and age of the CNNs and the reporting, there's no such thing as a secret. So you best out with the news first so you can shape how the news comes out, because it's going to come out anyway. And the last thing you want to be perceived as is withholding information.
But I guess I would challenge the Post's assumption that Virginia was withholding information. I think different decisions were being made about, giving exact locations of cases, giving, the distinction between confirmed cases and suspected cases. And I think that's a balancing act. I think, I would hesitate to judge that just because you're dispensing a lot more data necessarily means you are doing a better job of informing the public about real levels of risk and how they need to be responding. Because I think Virginia did a very good job in communicating risk and in putting in place what you would want from a public health standpoint to be put in place.
Yeah, I think you're making an excellent point, Jeff, that the media is not the only outlet. And for example, with school closures, we had a lot of conversation with state health officials as there were different pressures on them from their legislators, from their governors, the press to report different information. And the disconnect was that one week you're closing the school, and the next week you're not even telling anybody. And so who's the important party there? It's the parents and the families. And so you may not report it in the media that a school's closed, but you sure better make sure those parents know that there was a case in their school and here's how they can protect themselves. So I think that was probably far more important than reporting it in the media. And that needs to improve. It wasn't great everywhere.
And we need to be, you can provide a lot of information, but we also need to be doing good public health practice. And I thought one of the most ironic things that I heard throughout all this was that Rockville High School was closed because they had a case, but it was also the same week as advanced placement tests. And so they sent those same kids to a different high school to take those tests. Well, that didn't make sense from a public health standpoint, even though it may have given people a lot of granularity of information and gave the appearance that something was being done.
Here at Gall Metropolitan Police Department, the colonel said that, highlighted the need for ability to deliver critical services. And Dr. Jarris, you said that if the planning assumptions didn't pan out, CDC's planning assumptions for absenteeism say that in a severe pandemic, we should expect absenteeism to reach maybe 40%. Now, I think that if you think back to what Washington, D.C. was like when the sniper was roving around, and if you look at what happened in Mexico, that planning assumption probably doesn't pan out either. And I'd be very interested in your impressions about what it would be like if we have widespread school closures, sustained school closures, and people really get a dose of fear from a sustained and virulent virus.
Your turn.
Short stick again.
Bob, if you can repeat the question.
Sure. The question was whether the planning assumptions around absenteeism that have been stated for a severe pandemic, which are estimated to be 40%, really hold true in light of more recent events, subject to what occurred in Mexico and the local national capital region with the sniper incident, and how that would affect over long term. I think the answer is that like any assumption, it's worth the data that drives it. So I think that you do have reason to suggest that maybe we are either committing too much faith into that number or too little. Again, I think one of the challenges or opportunities we have, quite frankly, in this scenario is that we know what the answer is, and General Russell said it, it's vaccine. So in some ways, focusing on the opportunity and the need to basically produce vaccine and get that vaccine out is really something tangible that we can do to shape that assumption, quite frankly. I don't know how we can, we can say it's high, low, but we're only guessing. But I do know that we can basically challenge that assumption by suggesting that if we have not only the vaccine but the means, which was Jeff's point earlier, the means to get it out there and the workforce that Paul has suggested to basically administer that becomes the solution to that problem. Again, we can argue over assumptions. In fact, during my experience in the White House, we would spend weeks, months arguing over assumptions to different scenarios without realistic resolution, but or sufficient or satisfactory resolution. But I think at some point in time, you just to say, well, what basically changes these assumptions? And then look for those practical, real, tangible steps. For example, Frank suggested that in an earlier question that somehow we have to think more novel, in a novel way about the systems that we have in place today. I mean, in the bioterrorism scenario, we looked at the Postal Service. Maybe in the pandemic situation, we look at the use of pharmacies and pharmacists as a force a force multiplier, as used in the military setting. How we can basically expand the role of primary care into different settings. One area that we haven't touched on is alternate care standards, which is a very significant thing to help guide physicians to what they need to know is the appropriate standard of care to use in these kinds of settings. So I think the question about assumptions is fair. I think in some ways, given the benefit we have, I think we have to look at how we basically take those assumptions off the table, particularly if they create such fog and friction for us to understand how we would deal with the scenario.
I would agree with Bob about vaccine being so critical to this, and I completely agree about the need to deal with workforce, the need to deal with surge, the need to deal with surveillance. But the truth of the matter is, once we have enough vaccine, we'll figure out how we're going to get it into people's arms, which is not to say we shouldn't be planning for it, but somehow that will become resolvable. But I also think in terms of workforce assumptions, or people coming to work assumptions, I think the other part of that is in the absence of vaccine prophylaxis, and whether people are if we believe the recommendations that let me put it slightly differently. If the CDC believes its own recommendations about prophylaxis being a means of protecting people prior to a vaccine, then the policy response that needs to follow that public health recommendation is that the federal government assures that those who are part of the critical infrastructure are going to have access to that. And this cannot be dependent on the private sector or individual agencies making the right decision. Because where you live or how wealthy, how much cash on hand, which isn't very many businesses at the moment, your employer has should not determine whether you're going to be protected. If you are critical, then the government should be making sure that you have that protection.
Yeah, I appreciate the importance of vaccines, certainly, but we also have to remember that 4 to 6 months before we have a vaccine, maybe that'll be shortened in the future, and so we need to deal for 4 to 6 months in the absence of vaccine with an outbreak, and it's a little apparently easier this time, but if a full-fledged 1918 vaccine pandemic hit us, those 4 to 6 months would be horrendous. So all these other things, although imperfect, if we layer them together, are the best we have. Mm-hmm. What is it? You go to a pandemic with the army you have. Is that count as a military quote?
You got it. Well, the irony is, I mean, Bob, to your point, you talked about the U.S. Postal Service and its role it could play in delivery of the Strategic National Stockpile. I might note that in Top-Off, they were tagged with the responsibility and weren't aware of it themselves. So we do need to make sure that the right people are sitting around the table and we're not exchanging these business cards when the balloon goes up. I mean, that's part of it. And quite honestly, I'm not sure we're ever going to know exactly what we're dealing with, and we have to figure out, getting back to the risk management, what are we willing to, what exposure are we willing to accept, as we do for other sorts of everyday variety sorts of issues. Question here, then there, then there, then there.
I'm Linda Weinberg. I have the emergency risk communications background at Ogilvy Public Relations, so communications is a big piece for me. And several times I jotted down notes during various presentations about not enough thought has been given to the granularity. I love the thing, the quote about strategy is nothing and you haven't figured out the logistics. And we spent a lot of time talking about many of the problems that
want to summarize the Linda Ogilvy, but for the benefit of our viewers?
I think the summary of the question is that we've learned a lot about risk communication. We've raised a lot of the issues that have been raised about current guidances and implementation and how people respond. There's been lots of recommendations, lots of studies, lots of exercises, but we haven't sort of seen put in place the policies that would begin to address them. And I think it's partly because they're very hard. And I think it's partly because in many of these instances, we're dealing with political leadership that didn't want to deal with some of the ideological, perhaps in their view, ideological implications of the government playing a much larger role in people's lives and in developing a support system. I think there is the potential in the new leadership at HHS, for example, to take on those issues much more directly. The Senate needs to confirm some of those new leaders very rapidly. But I think these are experienced people with preparedness and response who I think are willing and have been with you, I think, asking those questions over the last several years, and I think would be prepared to try to develop appropriate policy responses. But there aren't easy answers to a lot of these.
We've got 7 minutes and a bunch of questions. What I'd like to do is, I know we had Matt, Tim, and 2 gentlemen here. If I can ask that all 4 of you ask those questions as quickly as possible, and then we'll turn it over to the panel to respond. So Matt, if you can please identify yourself.
Yeah, Matt Correa, I'm with Congressional Quarterly. I cover Homeland Security and intelligence issues related to what you're speaking about. And what I was wondering is, the overall budgetary picture right now, we have some of the largest deficits in years. Social Security and Medicare is going to become insolvent years earlier than predicted, as was reported today in the press. A lot of budgetary pressure is coming down on in a lot of different areas, and the things that all of you are talking about would be very expensive to implement in full. So, and this doesn't even take into account apparently the bioterror aspect of some of the developments that are related to what you're talking about. So what I'm wondering is, has anyone put a price tag on what's required of all of this fully, including pandemic bioterror? And how can you possibly get this through Congress, and can this actually be done?
Matt, I'm not meaning to cut you off. I just want to make sure, but the ramp up from the ordinary, what works every day as opposed to what worked for that really rainy day, I think those are really valid questions. Who do we have next? Tim, and then we had 2 gentlemen. Okay.
Tim Stevens, contractor with HHS. I want to circle back to Bob's national security perspective with a couple of observations. Mexico was in our sights through February and March and April. We're looking at Mexico for the failed state, the drug cartels. Yeah, we missed this, so I'm wondering where in our panoply of intelligence capacities are we going to be able next time find or miss something of this import? And then I think you've done a great job of connecting the global and domestic response, but how do we get back around to what ultimately is national security preparedness?
2 questions here.
Has there been any due diligence regarding...
Please identify yourself.
I'm sorry, my apology. Marcus McDaniel, Department of Agriculture. Has there been any due diligence regarding the efficacy of an N95 respirator, a mask, versus the use of a half-face respirator, which could be used for an all-hazards approach? We're going to suggest something. I believe it should be something where the cartridge could be easily changed for the use of first responders, whether it be chemical, biological, particular.
And final question.
Thank you. My name is Joe Strong from Security Management Bank. I understood Dr. Russell indicated in the near term, the country would be looking at as many as 3 flu vaccines, a regular seasonal, plus as many as 2 H1N1 vaccines. I'm curious as to the panelists' thoughts on the possible reaction and observance of a recommendation that people get as many as 3 flu shots in one season. And
I think we're talking about 2.
okay, I apologize then.
Yeah.
But then the second part of the question was, what does the calendar look like for the development of a single shot? What, in the best case, when would that come?
Why don't we start with that one and then go through? So, General, if you can just repeat briefly the question.
Yeah, the issue is having to give 2 shots. The trivalent seasonal flu vaccine, which has already been manufactured by most of the manufacturers, and which will be in the pipeline coming in September, and a monovalent H1N1 vaccine. It's theoretically easy to combine those and have a quadrivalent vaccine, but there are regulatory issues that we couldn't get over between now and this fall. There are logistical issues within the manufacturing processes that make that very difficult, and there are testing issues. So that the decision, I think, is going to be driven by all those considerations. We're going to be stuck with two different vaccines for this coming winter. The following year, I'm sure that the epidemiologic situation will drive it, but it'll either be one of the other seasonal vaccines will drop out, or we'll have a quadrivalent vaccine for the following year.
Jeff?
I'd make 2 points. One of the 4 questions. One is whether it's 2 times or 3 times that people need to get shots. I mean, I think that's obviously a huge practical issue. I think a lot will depend on how scared people are. And I think, despite all the hesitation about a vaccine, when a pandemic really does hit, and I think a lot more people are going to be willing to get a vaccine than you would normally see. And I think some people in industry are actually concerned that because of this heightened awareness, that the 150 million doses that they are making of seasonal vaccine for once will not be enough because there will be such a high level of demand. So that could be actually an unintended, an ultimate benefit that finally industry will see a return for their investment in that regard. With regard to the question of funding and how can we come up with all this money in the current fiscal climate, we make all sorts of decisions and choices. We're a very wealthy country, and even with the large deficits, we make choices, and this has to be one of them. If the government investing in protecting literally the lives of its people cannot be part of that investment, then why do we have government? And I think whether this is actually not something that divides people on partisan lines. I think the real issue around funding has been persistent attention. When we are not in the middle of a crisis, there's a tendency to think, well, we've taken care of that problem and we don't need to sustain the investment. That's the problem. It isn't a recognition that this is not I don't think there's question that for this kind of issue that there shouldn't be a government response.
You're suggesting Washington has ADD.
Yes.
Can I capture on that budget issue really quickly, just to give you some perspectives on that? First of all, we can't afford not to make these investments, number one. Based on a Carnegie Endowment study on our nuclear posture, we spend $57 billion a year on our nuclear strategic capabilities to deter adversaries from attacking us. We spent trillions of dollars over the life of the Cold War doing that, making that investment. On an annual basis, we spend about $5.6 billion on biopreparedness. Is it $10 billion? Is it $20 billion? We spend $10 billion on missile defense. I could suggest to you that we could find the monies to do this. The challenge has been is to basically equate the idea that public health is part of our national security infrastructure. That is the essential missing link here. That somehow people have not internalized this in a way that would make it an integral part of what we need to prepare for and how we need to protect our nation.
In a public health infrastructure, it has a lot more benefits than just a pandemic preparedness. There's an enormous day-to-day benefit to a strong public health, including food safety and a whole bunch of other health-related things. So it isn't. You're not just investing in pandemic preparedness. You're investing in a major support for the health of the country.
Yeah,
that has to be part of it.
I think they're excellent questions, and Matt, your questions about how we're going to get the political attention. I think this is a critical time. If we look at politically, I'm not sure I would want to be the senator or the House member who voted against emergency supplemental if things come back next fall. So I think that's in favor of supporting this. But also, as others have said, this is an economic necessity. I mean, look what's going to happen to our already down economy if this continues, and if we have these full social measures, and if we have a full pandemic and are not prepared. And then the national security, and I think this was an issue in 1918 also, how it devastated the military in the face of a world war. Our military needs to be healthy. Our civilians need to be healthy, economically viable. These are important economic and national security measures. How much enough is not clear, but if we just look at 300 million vaccines and estimate $10 a vaccine, which is what they typically cost us seasonally, and that's probably a gross underestimate, we're talking about $3 billion. Well, the president's requested $1.5 billion, and the House has $1.85 billion. Not enough money, not nearly enough money. We need a lot more here to be prepared, and I don't think that there's any political, economic, or security rationale to not make that investment.
Well, before joining me in thanking our wonderful panelists, and I think this discussion was incredible and could go on for many more hours, I want to leave the four of you with a token, figuratively and literally, a coin, building on military tradition, as we heard much of today, which is a reminder of common goals, unity, and the many issues we all face. And on behalf of GW, thank you, gentlemen. Thanks to the audience, and hopefully this is just the beginning of a long set of discussions. So thank you.
Nice to meet you. You gave me hope that we'll only need one dose.
Jeff.